Thank you, Dr. Said, Dr. Ashraf Rida, for the kind invitation. From what we started, we've seen a very good prepared session that overcame all the technical difficulties. And we had a very rich discussion, actually. With pleasure, I would introduce Dr. Ahmed Bendary, Associate Professor of Cardiology. He will give us the first flashback. Please, Dr. Ahmed, it's always a pleasure having you.
Thank you, Professor Hiba, for this introduction. And thanks for Yava for inviting me. It's always a pleasure to be with you all. Today we are in a very interesting educational session. This is Learn from Mistakes, and we are going to discuss 3 clinical cases which taught us lessons. The first case is a 31-year-old tourist who was found collapsed in his room by the housekeeper. He had been unwell with flu-like symptoms for the previous 2 days. He was conscious but drowsy and was clutching his right half of the chest, complaining of chest pain. She called for help, and the ambulance crew were on the scene 10 minutes later. They found him still in pain, drowsy, and peripherally shut down, with Glasgow Coma scale of 14/15, blood pressure 90/70, with regular tachycardia of heart rate 115 beats per minute, respiratory rate 30 beats per minute, and saturation was 100% on room air. Loading doses of aspirin and clopidogrel and subcutaneous injection of enoxaparin was given. Intravenous opiates were required for ongoing pain, and the patient remained tachypneic, hypotensive, and tachycardic. Intravenous fluids were started, and he was rapidly transferred to the nearest emergency department, and this was his ECG in the hotel's clinic. As you can see, there is some ST segment elevation in V1 and V2. On arrival to the hospital, the emergency team performed another ECG, and he was still in chest pain. Blood was withdrawn for routine lab tests, and the blood gas was sent. His chest X-ray was normal. The cardiology resident was called for discussion of a possible emergent coronary angiography. While the cardiology resident was on his way, the blood results came. The emergency department team gave an intravenous bolus of a certain medication and started an infusion of this medication based on the results. By the way, this was the patient's ECG in the hospital ER, more and more ST segment elevation in V1 and V2. And these were the lab results. Compensated metabolic acidosis, the blood glucose was 431, and there were severe hyperkalemia. The blood potassium level was 6.9. Classic case of DKA associated with hyperkalemia. When the cardiology resident arrived, the patient was less drowsy, and further history was forthcoming. He had diabetes and hypertension and smokes about 20 cigarettes per day. His regular medications include insulin and ramipril. The cardiology resident obtained another 12-lead ECG, which was completely normal. The ECG completely normalized. As the ECG was being performed, he noticed some small pilasters with erythematous space below the right axilla. This is pointing to herpes zoster, and this could easily explain the patient's right chest pain, and at the same time could explain the suddenly uncontrolled blood pressure and the DKA in which the patient suffered. 4 lessons learned. Number 1, there are many causes of ST segment elevation in the ECG other than STEMI. Be aware of that, please. Number 2, in patients presenting with any degree of disturbed conscious level, please obtain blood glucose. This is mandatory. Full examination with exposure of the chest in any patient with chest pain is very important, because this could leave a pathology even in the skin that could easily explain the patient's symptoms. Finally, it's important to be aware of the differential diagnoses that can masquerade as acute coronary syndrome, because inadequate and improper diagnosis could lead to a very poor cascade of unnecessary tests that could be harmful. The second case is a 61-year-old woman presented to the emergency department with a 1-day history of intermittent nausea, retching, eructation, and epigastric pain. Her past medical history include niacin fundoplication for large hiatus hernia 16 years previously. This was revised laparoscopically 1 year ago and before this presentation. Okay. The patient's only medication include BBI, lansoprazole. Examination revealed some sort of dehydration and mild epigastric discomfort, tenderness, but otherwise was normal. The patient was admitted for rehydration and possible endoscopy. Routine blood tests and ECG were also unremarkable. Abdominal erect X-ray was normal. She was admitted under the surgical team observation. She was prescribed analgesia and antiemetics and requested an upper GI endoscope after symptoms control, and this was her chest X-ray during admission, large hiatus hernia, airflow level in the pericardium. 2 days later, at 6 a.m., she developed intermittent dull retrosternal chest pain at rest and was referred to the resident medical officer. There were no risk factors for ischemic heart disease. The ECG was normal in the CCU, but someone noticed subtle ST segment depression in V4 to V6. So treatment of acute coronary syndrome was then restarted, and the possibility of urgent coronary angiography was discussed with the cardiology registrar. But what happened next was a surprise. Several attempts to pass the nasogastric tube was unsuccessful. The tube coiled in the mouth and would not pass into the esophagus, so the endoscopy was canceled and CT scan of the chest and the abdomen was requested urgently. However, shortly the patients collapsed and arrested, and the monitor still revealed sinus rhythm, so CPR with the algorithm of electromechanical dissociation was started. Return of spontaneous circulation was done after 2 cycles of CPR. No drugs were administered during CPR, and the patient then were intubated, ventilated, and started on inotropes. What happened? The bedside transthoracic echo revealed that the left atrium was barely difficult to be visualized and appears compressed by an extrinsic mass that moved asynchronously with the left atrium. And this could easily explain, by the way, the electromechanical dissociation and the cardiac arrest. What to do next? Should we move the patient to do CT chest, taking the risk of moving this high-risk patient outside the CCU? This patient is unstable, post-cardiac arrest. Or should we do upper GI endoscope bedside, taking the risk of possible esophageal perforation? What happened is that the team decided to do upper GI endoscope in the CCU, and boom, acute gastric volvulus was diagnosed. The patient was taken immediately to the operating room, reduction of the volvulus was done, and revision of the fundoplication was performed. The patient underwent stress myocardial perfusion after 3 months that came normal. 3 lessons learned. There are cardiac and non-cardiac causes of chest pain. Please, you are a physician before being a cardiologist. Always correlate the current situation with the past history. There is no unlucky patient. Finally, bedside echocardiography is invaluable in diagnosing non-cardiac, and I'll say it again, non-cardiac causes of chest pain. The last case, and this is a very nice one. It's a funny one. The wife of a 78-year-old man noticed that he would occasionally wake up from sleep, sit up, gesture whilst mumbling a few confused words, collapse back, and then return to sleep. On each occasion, the patient was pale, cold, unresponsive for several minutes after returning to sleep. And on waking the next morning, he would be distressed by short periods of retrograde amnesia, lasting up to 4 hours before the event, and he was otherwise completely unaware of these episodes. هو اتجنن ولا ايه? These were the words told by his wife. Neurological and cardiovascular examinations were normal in the clinic. ECG, carotid sinus massage, even echocardiography and the 24-hour Holter monitoring were unremarkable. Computed tomography and MRI of the brain showed just minor atrophic brain-related, age-related changes, non-revealing. What happened is that the patient was given some antipsychotics with a presumptive diagnosis of senile dementia. However, his wife brought him back again after 2 weeks. The frequency of the episodes was increasing for the past week, and she told us it's occurring now almost every night. One senior neurologist ordered a very brilliant and intelligent maneuver. He ordered overnight combined ECG and EEG monitoring. And at 2:20 a.m., The EEG showed a start of a seizure activity and followed, as you can see, by slowing of the heart rate. After 5 minutes, the heart rate progressively slowed until the patient developed profound bradycardia and asystole. And then, after just 6 minutes, there was termination of the seizure activity. You can compare the activity of the brain before to the activity of the brain after, and the heart rate returned to normal. Do you know what is this called? This is called ictal bradycardia, or seizure-induced bradycardia, and it could never be diagnosed unless you do combined EEG and ECG monitoring, because if you didn't think about it, you will not get it. The patient was treated with an anti-epileptic, sodium valproate, Depacin, and he was inserted Berman pacemaker with excellent follow-up up till now. 4 lessons learned. These are very smart lessons. Number 1, drop attacks with true loss of conscious level could be due to either a cardiac cause, syncope, or neurological cause, epilepsy, but both can present together. Please don't assume until you see. Please don't assume until you see. Brain and heart are truly connected. Finally, combined ECG and EEG could solve the problem in patients with unexplained syncope, especially when preceded by neurological manifestations. My take-home message for the second time are those 10 commandments for avoiding clinical errors as provided by Professor Adam Sifu, Professor of Medicine in University of Chicago. I read them with you. Number 1, pay attention to the chief complaint recorded by the nurse. Number 2, really attend to the vital signs. They are truly vital. Number 3, always assume that the doctor who saw the patient before you was smart enough, but never blindly accept a diagnosis made by another doctor. Number 4, consider drug-drug interaction and renal functions when prescribing any medication. Number 5, if your decision to discharge the patient will keep you up, reconsider this decision. Number 6, if your decision not to evaluate a complaint will keep you up, reconsider this decision. Number 7, never exclude a diagnosis because of absence of signs and symptoms. Number 8, never be afraid to ask for help. 9, slow down, relax, listen, and think. Number 10, keep a list of errors and review it often. Thank you.
Thank you, Dr. Bendary, for an excellent brainstorming talk.
Thank you, sir.
You really caught my breath.
Thank you.
It's very interesting. You opened our mind to new ideas that I think all of us would make benefit of. And gladly, Dr. Yasser will introduce the second speaker.
If any question or comment, a quick one. Yes, please.
This is a very excellent question. However, clinically, sleep apnea is not characterized by disturbed conscious level or some sort of amnesia or dysphasia like the clinical picture of our case. Sleep apnea characteristically awakens the patient from sleep, and the sleep partner usually complains of some sort of snoring, and this could be easily diagnosed by over the night carbon dioxide monitor or sleep studies. However, this patient case was extremely different from that scenario. The patient is awake, unconscious, gets some understood words, and then he had the next morning amnesia. In an old age, this usually points to some sort of dementia, but at the end of the day, it turned out to be another diagnosis.
Ahmed, thank you very much. In your last patient, could you consider sixth sinus syndrome as a differential diagnosis and proceed for Holter? Could you consider sixth sinus syndrome as an option or maybe a probable diagnosis?
Actually, this is a tricky point. Which came first to solve the problem? Because sixth sinus syndrome or sinus node dysfunction can lead to syncope, and prolonged syncope can cause convulsions. This is called convulsive syncope. However, if we notice the recording, the attack of seizure in the EEG started before the onset of the bradycardia. if the onset of the bradycardia and asystole have led to some seizure activity subsequently in the brain, I could agree with your opinion, which is respectable. However, as you can see again, the attack of seizure in the EEG started about 1 minute before the onset of the bradycardia. So this is a seizure-induced bradycardia or ictal
Ahmed,
bradycardia.
you know, practically, I think no one from
practically,
us,
the physician
could ask
ordered-
for
yes.
EEG combined with ECG. So I know I will not ask it for EEG and EEG
The
concomitant with
EEG and
ECG.
the EEG and the
Yeah, it's the same time.
ECG were not ordered except after the patient did a 24
And
Holter monitoring
separately.
normal,
And
carotid sinus massage normal.
Yes.
The physicians suspected sinus node dysfunction or some sort of sick sinus syndrome before ordering.
Ahmed, this is called a sleep study.
Yes.
Which I think there is a lot of labs now in Egypt. We have one in our chest department to study the respiratory pattern and the ECG pattern and the EEG pattern. It's very important in some cases. One of the comments here, which I think is also important in the first case, the first lesson we learned in our clinical rounds is to expose your patient very well.
Ah, yes.
It's very important, please, to expose your patient, because sometimes it is missed because of lack of good exposure of the patient. This is number one. Number two, remember that sometimes the neuropathic pain precedes the eruptions. So you have also to think about the herpes even without eruptions, because sometimes the neuropathic pain starts before eruptions. This is also another important clinical trick. And finally, the take-home message, which is elegantly presented by Professor Bendary: do not have a fixed thinking. You have to have a co-thinking, and you have to have a co-management. Those are very important 3 messages for managing a clinical scenario cases.
Thank you.
Thank you very much,
Thank you,
Professor
sir.
Ahmed.